We get lots of questions about the use of medications to help with insomnia and sleep maintenance in children. Obviously, a lot of these medications are prescribed by general practitioners and pediatricians, and for the most part, some of them are fairly safe and most likely not all that effective, though, when it comes to actually changing a sleep pattern. The use of sleep medications for insomnia is never considered first line by most people in sleep medicine because the insomnia is usually a reflection of something else that is happening, whether a primary sleep disorder hasn't yet been diagnosed or whether that child truly has an anxiety disorder. Those require very different medications and very different treatment strategies, and thus just a blanket recommendation on sleep medications as a whole in pediatrics is a difficult one to make. Certainly, in certain situations, an occasional diphenhydramine or Benadryl or an occasional use of melatonin is unlikely to provide long-term detriment to your patient, and they are, for the most part, safe, but certainly should not be used on a long-term basis without routine supervision of why that person is receiving medications for insomnia. Melatonin is something I get asked frequently about, and melatonin can be used in two ways. You can take a dose immediately before you'd like your child to fall asleep within 30 to 60 minutes. That's what we call a hypnotic dose. Or you can take it 3 to 6 hours before your desired bedtime at a slightly smaller dose, and that's what we call a chronobiologic dose. And that dosing 3 to 6 hours beforehand is really something where we're trying to shift their overall circadian or biologic body clock, and that's a little bit more difficult to do. In either circumstance, if you have a child who you feel like warrants evaluation for more routine use of sleep medications, that's something that should really be discussed with that child's pediatrician, general practitioner, and possibly even a sleep specialist.